Today on the Pursuit of Health podcast, we kind of went out on a limb and I tried something different. I got together with some neighbors and colleagues, two physicians, Dr. Phil Wilken and Dr. Avi Silber, both pediatricians who happen to live in my own community, and we sat down and carried on a conversation that we had begun outside in another format. And we think this was interesting because it started showing what we think as physicians about how healthcare is financed. Where are we spending our money? And we had our own opinions about this, so we sat down and hopefully created a very informative discussion that you will all get something out of. We believe in what we're doing, we're passionate about it, and both these doctors, who I consider to be dear friends, actually demonstrated that they have a vision for healthcare which is centered on the patient. And it's not so much what we spend, but how we spend it. So join us on this episode of the Pursuit of Health podcast with Dr. Avi Silber and Dr. Phil Wilken as we discuss how do we spend our money in healthcare. So welcome everyone back to the Pursuit of Health podcast. I actually have the pleasure right now of sitting with some neighbors. We have some doctors in my neighborhood. And yes, like everybody else, we sit and talk about things. And in our case, we talk about medicine. And eventually, as the weekend goes on, we start talking about other things like our family and dogs. But right now, we're coming together because we started talking the other day about something that we, all three of us, started to realize we shared in perspective on. And that's a little bit about how the money is being spent in healthcare, in our careers and where we work and what we've seen in our perspectives about that. And I thought that would be a very interesting topic to just sit back and invite everyone to kind of peek in and listen to our conversation about what we think about the financing of healthcare or what our perspectives are on that. Because I know we all had some strong opinions. So I thought I would sit down with you and take that conversation out at large. I think it's a kind of conversation that a lot of people don't have. We don't talk about the money of healthcare because it's almost taboo as we're training. And it's very funny that way. But I'm like, but we've got to, because if not, either we're going to be not in control of where the money's spent as physicians, or we'll turn around and find out it's being spent in places that we don't think makes sense for us to do what we need to do to take care of our patients and deliver good quality care. So I thought it'd be an interesting conversation to have, and I'd like to welcome my two neighbors and colleagues. I've on my left here, Dr. Philip Wilken, a pediatrician, actually internal medicine and pediatrician double boarded. And I have Dr. Avi Silber as well, who's also in pediatrics. Mm-hmm. So I'd like to just have everybody get to know who you are. So why don't we start again that way? Give us some background, Dr. Wilken. A little bit about, when you first thought about kind of being a doctor and a little background in your school and where you are today.
Yeah, so I trained actually down in Richmond, Virginia, and where I did my residency after Albany Medical College, where I did my medical school training, and then made my way back up here. Have a lot of roots up in this area on my wife's side of the family. And so it was just by luck that we were in the Middletown, Orange County, Sullivan County area. And I was, when I first came up here in a primary care practice specifically, and then we branched out, and now I work in a special needs based practice in Sullivan County, so very rural based.
Right, over at the Center for Discovery, where we did one of our episodes on, and I know you're the medical director there. So how long have you been a physician, practicing physician now?
Oh, amazingly, 21 years.
Goes fast, right?
Yeah, it goes very fast.
Yeah, we all remember being in school and all the things we learned, and all of a sudden scared to be out on our own. Here we are 21 years later. So originally also, I think you had Cornell University in your background as well. Is that where you
did my undergrad there.
Undergraduate there?
I was one of those people that thought that in high school I wanted to be a doctor. So I started out early with that thought. So yeah, it's been something.
Persevered and made it through so far.
Yeah.
Okay.
Did the pre-med thing, and so it worked.
Gotcha. So from New York down to Virginia and back to New York. Okay. And Dr. Silber, tell us a little bit about your journey from thinking about being a doctor and where you are today.
Yeah, I think it's interesting. I look back when I was a business major in Binghamton, SUNY Binghamton State.
All right.
And I did really well. And I had some friends going pre-med, and I said, that's so great. They're going to go into a field where they can help people. And my grades are good. I said, why not? I want to go to medical school too. So, ended up switching midway through.
Interesting. So we're talking about medicine, and you started the business of medicine and the finances, and that's where you started.
I didn't get that much coursework done, but, the basics, but my head was there.
Gotcha.
Went to, Philadelphia, Temple University Medical School, and back to New York City, St. Vincent's for pediatrics. And I think when you talk about, the different things I've done in my career, the first was what you would think of as a regular, very suburban pediatric practice, what, a lot of us just went to growing up, and very busy and almost like kind of mill-like. And I didn't want to leave the city, and I had this opportunity, which I think was just really interesting for me, to work in what people describe as a boutique practice. It was on Park Avenue, and it was Park Avenue.
So take a step back for a second, because we use these words a lot, and I think that's something to describe. We use the word mill, and then within our own profession, we kind of know what that means, the mill practice, or a hospital where it feels like a mill. Explain to people what that means.
So it wasn't, and I don't want people to go back and say where I went, but it definitely felt like you would try to see a lot of patients fairly quickly. So really emphasize, and it depends. In pediatrics, in the busy season, you could see a lot of them. So it felt, very busy, especially coming from training.
Right. And so the concept of the mill for everyone is really this idea, we feel more like a cog in a machine than we feel like we're actually making connections. And that mill idea of it being more mechanical than it's really being emotional.
Yeah. And it really kind of felt that way, just more coming from residency where things were slow. But I think it was pretty typical.
Gotcha.
And then they did really good medicine, but then I changed to the opposite, I would say. So when I say boutique practice, there's different models of that. There are some where you'll hear where people will pay like X amount of dollars to be part of a limited size practice. So you're doing the opposite. You're spending a lot of time with patients. This one in particular was just, we didn't take insurance, and because we didn't have to deal with all the extra dollars that went after going after, I think part of it was just going after, billing that didn't get paid. You didn't have a big staff going after the billing, and you were able to keep a smaller practice and see less patients in a day.
So that's an important aspect for everyone to understand, that the overhead of just trying to get paid, to get the reimbursements back, has a cost in it that is being kind of passed on somehow, or has to be considered as part of the big nut when you're talking about your business background. And a lot of people don't realize that's a big chunk. Just to go after the money is a big part of the healthcare when you're running a practice or running a hospital. And that if you don't have to do that, you can pass that money on to some other area, whether it's your salary or your staff or some other aspect of your care.
Yeah, I mean, the coders tell me that you're pretty much going to get 10, 20%, something just rejected right away, because what I'm told is hopefully you don't refile that, and you actually end up not billing for that. That's kind of like a trick. But this was, hey, we have your credit card on file. We'll see Johnny next, in 6 months from now, and, we'll take care of it. And some of those people could, if they were lucky enough to have a plan where they would get reimbursed outside of network, they had that, or it was just okay. I'm talking about these were people that could afford it. So if they could just pay out of pocket,
So in some sense, the commodity that you were buying was time.
Mm-hmm.
You could spend more time with them than you could in the, quote, mill type setting, because that money that was going to be spent for the overhead of all those other things related to reimbursement had to translate that you could sit down and spend more time with somebody.
I would say maybe you see 10, 15 patients on a busy day there, sometimes less. And if you're talking about where I work now, I'm somewhere in between, but if you're talking a regular suburban practice, you're maybe seeing 30, so double.
That's
kind
a
of
good
the
perspective.
Amount of that. So it's definitely, and also in that time, and this is what there were some things with the medicine there I didn't feel like,
right.
And we'll talk.
And we'll definitely do that.
But I think the one thing, if I have to go back and say what I learned, and I learned something everywhere I've been, is how to be a fierce patient advocate. So that's how my boss felt my job was. My job is to make sure my patients, not necessarily to treat patients, but to make sure that patient got to the right specialist. And I had the time to call up that specialist and say, this guy's coming over and this is what I'm worried about. And I spent a lot of time.
So time outside of the direct patient contact, there was a lot of time behind the scenes that you were doing.
Yeah, and I would even say some of the other ones where you limit your practice size, the doctors will go to your specialist appointments. I didn't go quite that far.
So that's what the boutique was, much more of that in the boutique setting.
And yeah, and if I remember I had the keys to the office, and if someone had an asthma and they would expect me to go, maybe go open up the office and give them that treatment, not to go to urgent care.
So far this sounds wonderful, but we're going to talk in a moment about what made you change and some of the things that actually changed your mind on what on the surface sounds wonderful.
Yeah.
And I think for Dr. Wilken, I mean, you're working in a setting now with children that have special needs that come from all different backgrounds, and the time factor and how much time you have to spend with them in that setting versus being in an outpatient private practice setting. I think you have a perspective there. So tell us a little bit about that kind of setting and how you spend your day now.
Yeah, it is very different in the sense that I have a lot of contacts, a lot of extra work, as you were saying, during a visit when I have subspecialists and other people that I need to contact. So a lot goes into a visit. And so we were talking a little bit about the mill before.
Right.
You just can't do that with the special needs population. And it really requires, a lot of coordinating and, a lot of time outside of the visit itself as well. So, one of the things and one of the reasons I enjoy working with the special needs population is because it does give me that opportunity. And, as I teach many of the medical students that come through there, it's just not possible to have a mill in order to deal with those issues.
Not if you want to do a good job.
Exactly. And it, the bottom line, one of the challenges is that, with the billing, you have to, you're trying to recover as much as you can during a visit because you are seeing less patients during that time.
So give us a sense of how many patients you're seeing. Dr. Silber was talking about, approximately 30 in a busy office and 15 in a boutique. So give us a sense, how many patients a day are you attending to in the office setting or in another setting?
Probably on the order of about 15, like you're saying. That's about...
Okay. So here, that's already interesting. Step back for a minute. Your boutique practice, 15 patients. A special needs practice where it's not necessarily boutique, but it's an environment that's geared to them, 15 patients. Already there's a sense that time is a factor here, and that you're both need to spend a certain amount of time in both those settings. So we'll talk a little about that. So, Dr. Silber, and we'll say Avi for everyone now. Right. So Avi, tell me a little bit, because at one point there was something that just didn't quite jive with you anymore. It didn't make sense that this was the way that you wanted to do this, and you made a change. And what were the factors that kind of led you to change?
They were personal and professional. But I would say the other side is you don't necessarily need. So there's this concept out there that I want the best medicine that money could buy. Right. And there's this concept of I need to get what I'm paying for. So you don't necessarily need to spend a half an hour with somebody that's coming in with a cold, right?
Okay.
You pretty much could take care of that and now we can take care of a lot of that on the phone even.
All right. Telehealth and things like that, right?
But, there's a sense if you're coming in for a cold in this practice, you're going to get, if you have a fever, you're going to have blood work because we can, and we could,
in the boutique setting.
So you can get the blood work and you're going to get the white count. And is that evidence-based? Is that helpful when you're coming in for a cold? No, but you feel like you're getting more. Oh my God, the white count was high, which, on a very basic level, we say that means infection, right? But it doesn't really in the setting of a cold. What do I do now? So I got a chest X-ray because I had a high white count,
Right. So now you're down that slippery slope.
Yeah. Then you go, this is what we're talking about. I got the chest X-ray. Well, there's a little bit, I'm going to use this term, a little bit of schmutz there, right? not a pneumonia, but you can always, when you look at something, you can always find marking, oh, maybe the pneumonia there.
So there's an element in all of this where it's kind of trying to make the person feel like you're doing more, yes. But you're not, in that setting, you were saying, I'm not sure I was really, that was making a difference in what my ultimate decision was.
Ultimately, it may end up putting on an antibiotic, which is not great for the patient. But
they feel better when they walk away with something.
They got like super high level of care, and I think the damage of that too is like when you're or not the damage is like a strong word is now you feel, oh my God, thank God I did this. The next time I had a cold, look what happened to me. When really. It could have been a 5-minute appropriate visit.
And they start to expect that. It's sort of, you're also, the message you're saying is that that's how a cold is handled every single time.
Right. And then the intentions were good, but sometimes really kind of think, and we'll talk, so giving the patient what this high level of care when it doesn't necessarily need to be there, or fulfilling patients. And it takes a lot more time to tell someone, hey, this is a cold, you don't need an antibiotic, you don't need this. And make the patient happier is really a better outcome for them. So, right, it wasn't just, okay, I got this one antibiotic and x-rayed one time, but it's like, now it's like, oh, this is how things are handled.
And so every time they come in, they're expecting something like that in that setting. It creates a different practice pattern automatically, that those are the expectations in that environment.
And I think use of specialists were there too. It almost became like, oh my God, I have an ear infection. Who's the best ENT that I need to go to, right?
Gotcha.
But you don't necessarily, need all that.
Not for that. That can be handled by your general physician at this point. So you use the word high quality of care, and what you're really saying is, at some point you start to realize they think this is high because I'm racking up, so to speak, the resources that I'm using, but that doesn't translate to better care. And that kind of changed your perspective on what you wanted
and
to
also
do.
that perception of, if you didn't kind of get what you want, it was kind of a smallish neighborhood or community. So you have to be really, really careful about the perception of what you did. If someone wasn't happy, it was really the ramifications that were hard.
And we'll hark on that in a moment about the idea of perspective of someone. And how it translates to, is it really better quality in a moment? So, for you, Phil, the idea of, is money being spent the right way? Again, you have very complex patients, and the idea in your setting versus practice, do you think that your training and your background tells you, when I work in this kind of setting, I'm really doing what I need to do to take care of that patient, instead of the idea in a different setting that Avi's talking about, where, this doesn't need to be done, but, it's expected. Where is that different in your situation or where you're working now?
No, it's, I had a parent say an interesting thing to me one time. And, it basically, the way they were trying to get their point across is that they weren't used to a primary care physician integrating some of the specialist visits, and the expectations for a primary care doctor, I think, have changed over the years. And I think, basically their point was that they felt very comfortable having a primary care doctor integrating all of those different things when they knew that it was being taken care of, if that makes sense. So, in their past, in other, before they came to the center where I'm at, it may be that they had a doctor, primary care, and it was difficult to have all the specialists, to keep track of everything. And I'm spoiled at the center where I'm at. It's easy to interact with the specialists because we have them there sometimes. And so
so you become truly, in that situation, in that setting, the center for the patient is going through the general physician a lot more, whereas in a complex patient who's out there in the world, and I know this as a specialist myself, the patients are kind of going every which way but loose, and they may not be coordinated care. So you're delivering it differently. And does that affect, so to speak, the efficiency that you order? Or maybe you order less tests, you do less because you can talk to someone down the hall and say, look, do I need to do this or not? And the patient benefits from that. Yet they see you as the center of that process and don't necessarily need a script, need more blood tests to say, I talked to so-and-so and this is what we're doing. And that changes the way the care is delivered.
No, I think you're absolutely right. It's just having that relationship with tertiary care docs or the specialty docs and the primary care docs is key. And, I think developing that care group so that you're dealing with people that you practice with all the time absolutely makes it easier because you know what they're thinking. Oftentimes they know what you're thinking, and then you can, have a conversation.
So the organization of your general physician and in some cases the needs for specialty care is coming up in this discussion, and how that's organized may very well be related to how much is spent or where you refer or what you do. And I think that's a topic perhaps even on its own right, is how do you coordinate the general care through the primary physician into areas of high need, and do you sometimes over refer because that's an expectation in a boutique environment, and in other settings, perhaps under-refer because you just talk to someone down the hall. It's interesting how you've got those two playing against each other.
I mean, and we don't want to jump ahead too. There's a couple things. It's patient expectation too. It's interesting. And we didn't go ahead to where I went. I ended up in a federally qualified health center.
Right.
So that I take care of a lot of what we would call underserved but in New York.
And you made a conscious decision that boutique environment wasn't sort of hitting your calling or what you thought this should be about. So you made a change because, go ahead. What was?
I would say, I was thinking about this because before I came here, and I really, what I took from that practice was really to being an advocate. I think the expectations there were one from the patient, but I wanted to do more for my patients. I wanted to help patients that were needy, and I remember looking for a job, and I was ready to leave the city, and I remember. This is how I don't feel like I'm getting old, but I looked for my job and I found it in the New York Times, maybe in the New York Times online, and I read a mission statement, healthcare for all people that deserve privileges, and I just read it and I felt, this is what I want to do. It just seems so much.
But you weren't feeling that where you were then.
No, I was not.
Right, it was the money was there, but that wasn't enough. You're looking in the New York Times for some reason. Some people think you're looking in the New York Times for a job. You need a job. You're saying, I didn't need a job. I had a job, but.
Well, and just to be kind of fair of where I am, this is something I was looking at other practices up here, and this one really spoke to me. And then part of it was something called the National Health Service Corps, which could be another tangent, but that's a program where doctors who want to go into primary care and work for underserved populations could get loan repayment from. So I said, let me come up here, try this different life, and meanwhile get some loan repayment done. And I'm probably a poster boy for that movement because then they said the whole idea is to get people in there and hopefully they'll stay.
Right.
And that was,
that's the goal of that system.
14, 15 years ago. So I stayed.
So you stayed.
So it worked. It really did work because once I practiced in this environment, I didn't want to change.
But there again goes the cost. And I think that is an important subject in the cost that, again, we can bring into people who may not understand. There's that element of our education and the cost that physicians bring with them as they enter into the field. We have debt, and the debt is just only going up. So that is a cost factor here, right? And as we go into that, either we find jobs that are going to pay us a significant amount of money so that we can make our debt go away, because nobody likes carrying debt. Anybody like carrying debt? Not me. So you're sitting there doing that, or there were these other opportunities in certain communities, in areas such as Newburgh, New York, and other areas in the city and stuff, who said, look, if you work in these underserved areas, it'll be a win-win. We'll forgive some of this debt, or a significant portion, if not all of it, but you need to give us a certain amount of time, and let's hope you fall in love with this and stay. And so that becomes part of the cost equation in the business model. The physician's already thinking financially because we're coming out of school with debt.
The debt that the medical students that come through me now are racking up is dwarfs what I had, and it really it has to play into your decision. And just imagine you changed your mind. And I said, man, I don't want to be a doctor. I think about that. It's really when you're 20, whatever, and you sign that loan, you have no concept of what you're signing on to.
Right. And I think people are very, feel sort of trapped about the finances, even though they went into it with good intentions. And I think that leads us to the next concept, something you brought up and alluded to, is patient satisfaction surveys. The idea that somehow somebody decided that in order to improve the quality of care, we had to make sure the patient was satisfied. And we're kind of touching on that surface, but somebody monetized that idea. They actually said, well, maybe we can improve quality by making the patients happier. And if we can do that and see that they're happier, the insurance companies can incentivize us as physicians by basically giving us a reward, saying if you do well on these scores, you get paid well. But there's the contrary to that, which is if you don't, there might be a penalizing effect. And here we are walking in trying to make a decision where we're going to work to do what we're trained to do, but also pay our debts. And there's this other factor. We have to satisfy this patient satisfaction survey. And we have to think about, wait, am I really satisfying the patient for ulterior motives that are not making sense for the patient, for the quality, or really for what I'm here for? But that is where this is headed. And necessarily, that's not better care either. So what factors of these patient care surveys where somebody says, I really like Dr. So-and-so in that hospital, and you get a good score? Most people don't realize the insurance companies watch that now. The hospitals look at that. And how does that play into our discussion here about, are we really delivering good care because they feel satisfied? We ordered more tests, we did all this, or what is really the quality we should be aiming for? So what do you think about that?
Well, I think, at the center where I work, and, maybe Avi, I don't know if you have the same thing, we have decided to become certified a patient-centered medical home, which is basically a bunch of different areas of patient care, including monitoring your progress with different measures of care, say for seizures or for diabetes, that you're getting certain lab work over certain amounts of time.
So you're looking at outcomes ultimately.
So looking at outcomes, and with the patient-centered medical home, it does take into account, as you're saying, patient care and the perception of patient care as part of what what you're doing. And so in that case, I think it's a great guide. I think, in trying to be sure that you're satisfying different patient needs, whether it's how a visit went, and if the practitioner was attentive, if and just getting feedback. So in that case, it's important.
But what ultimately matters is what you said is the outcome. Mm-hmm. Does that translate to that kid having less, in the case of a child with severe autism and behavior associated issues, is that person now able to be more integrated into the classroom and at home and stuff? That's the outcome we're looking for. And asking that question, and the question really is are the patient satisfaction surveys, or the medical home criteria, are they all focusing on the right criteria? And you're saying in your case, you think the outcomes probably, it does make a difference, and when you try organizing it as a medical home. But are there times where it doesn't actually get to the heart of what the outcome is trying to be?
Yeah, I think some of them are really important, and you kind of alluded to them. So, and this is what I tell my part of being a doctor is being a salesman, but it's telling the patient to believe you and trust you, because if they don't trust you, they're not going to follow your advice and they won't do well. So there's always a couple of questions there. I think it's probably, do you feel like your doctor spent enough time with you? Do you think your doctor listened to you?
Time again.
So if they don't have that perception, they're not going to take your advice into care. And that's what I kind of tell my medical students. I said, if I can tell them, that it's just a virus, it's real simple. It's just a virus. Like, you don't need to do anything. But if I do it in a kind of inattentive way where they don't believe me, they'll probably show up in the ER because they didn't listen to me. On the flip side, right, my role as an administrator, what are a lot of the complaints we get? Sometimes our patients didn't get exactly what they wanted. Sometimes it's related to pain meds they didn't get, or the test they wanted didn't.
They expected a test or a prescription or something.
Right. So those are the ones we have to kind of pay careful attention to and not just say, I'm going to give them whatever they want. Because our job is to give them, the patients, like our best advice and the right, medical care. But I think, if you do that other thing right, listen to, attentive to, you'll do well. And I think watching our cycle time, which is
right.
But they did, I did send you a study earlier where you're more likely to just give someone an antibiotic that they didn't need, order an unnecessary test that they didn't need. And tests are not necessarily
So we're cautioning, not only the payers, but our patients, most importantly, and our colleagues and our student colleagues to say, what really is important, it is important to know that the patient feels like satisfied with the care they're getting, but how you achieve that is important. And we need to dictate that in a way that is not actually superficial or not truly dictating what the outcome is going to be. If we go off into ordering all these tests because people feel better when you do that in a boutique setting and do all that kind of stuff, they may feel better, but the end result will not necessarily be better. And that's a problem because ultimately that cost goes up and the outcome doesn't change or gets worse. And that's not what the outcome needs to be. So somehow you're both saying, if you spend time with the patient, make a relationship with them, and explain to them about their illness, essentially teach them, tell them what you're doing, why you're doing it, or why you're not doing it, then that actually creates satisfaction. It takes more time to do that, though, right? That's a commodity, time. So that keeps playing into this. But when you do that and you bring the patient along with you instead of 5 minutes in and out the door, then you end up spending more time, but spending less money and get a better outcome. It goes back to that relationship building again.
And that's really, I think that's still, people say, like, the art of medicine. There still is that relationship there because people want to hear it from someone they trust. It can't just be all algorithm.
We hope you enjoyed this conversation with two exciting colleagues of mine who have a very strong passion for what they do. They both started with higher education and had a calling, I would say, to get into medicine. Each one of them had their own path, but eventually came to the same conclusion. It is the time that we spend with patients that is the biggest commodity. Dr. Silber started in a boutique practice where he had a lot of good lessons learned there, but realized that there were things that he wanted to do for the general population and feels more fulfilled now, though he did learn quite a lot in that boutique setting. And then Dr. Wilken, who sat back and said, there are some very special needs people. He, as I know, has the compassion and the empathy to work with them, and he has done some wonderful care there and believes very much in where we're heading with the patient-centered home. So, I believe what we all brought to this was, as we're getting into our 50s, we have some experience now. And we wanted to share that with you all in terms of how we on the front line, physicians who are caring for patients day by day, believe that the money can be best spent so that we can get the best quality for those we serve. So I hope you all enjoyed this episode of the Pursuit of Health podcast. And as always, I hope this is informative. We look forward to your questions. And I'm Dr. Fethke, wishing you well in all your pursuits.